Really honored to be here today, and also happy to be able to share with you some promising news, at least in the short term. So the current COVID-19 situation, I think as all of us know, is rapidly improving with continuing favorable trends, which I'll highlight on the following slides. And after I review the relevant COVID-19 numbers, I'd like to briefly touch on two relevant topics. First, the Test to Treat initiative, that's one component of the recent pandemic roadmap that was described in last week's presidential State of the Union address. There's some confusion about that I'd like to clear up. And then second, I'd like to describe the difference between the meanings of the words pandemic and endemic, especially when we refer to the current and future state of COVID-19. So just in terms of our numbers, those of you who have been tuning into the MMAC webinars know that these are much, much better than what we were seeing even a few weeks ago. Our daily average, 7-day average of new cases continues to decrease very steeply. We're now down to 467 per day. Our positivity rate by test is under 5% and dropping, which also is very favorable. You can see 3.3% in Wisconsin and 2.7% in Milwaukee. And the reproductive number, which as most of you already know, is a measure of whether the pandemic is growing or shrinking, is favorable, being under 1 at 0.81 in Wisconsin and 0.82 in Milwaukee. And what's important to note is that the R value has been substantially below 1 now for about 6 weeks. So really, really strong, favorable trends. Similar trends here in Milwaukee. Our 7-day average of new cases is down to 30, which is really, really quite good. But you can see on the right, the burden of disease in Wisconsin and in Milwaukee since the beginning of the pandemic, now 2 years ago, is very high. So if we can go to the next slide, please. Deaths and hospitalizations, deaths are trending very favorably. We were averaging over 30 deaths per day in January, and now we're down to 9 with the trend continuing to steeply decline. Hospitalizations also are down 85% from the peak that we experienced in mid-January, now at 366 hospitalizations yesterday. And our ICU census also is down 85% to 67 yesterday in Wisconsin. If you look at the bottom right, the trend is the same here in southeastern Wisconsin. We have nearly half the hospital beds, and our ICU census is also down significantly at 33. And there is some relief in terms of utilization of both hospital beds and ICU beds in the state. And this would include people with COVID and people with other diseases not having a diagnosis of COVID. So we're down under 90%, again, for the first time in about 6 months now, at 85.6% ICU occupancy rate yesterday and 87.9% hospital bed occupancy. And this is really important. We have staff who've been working hard for 2 years. The limiting factor in our ability to render high quality patient care to people isn't really the number of hospital beds we have. We can actually create new capacity. It's staffing those beds. So these trends are very, very favorable and welcomed for the healthcare workforce. I can go to the next slide, please. Again, you can see the trend data. These are screenshots captured from the Wisconsin DHS website yesterday afternoon. And you can see that compared to where we were a few months ago, and in fact, even back to August of 2021, we're in a really good place. Cases are declining, and the trends appear to be very favorable. Also, deaths are declining, and I would note that although Omicron caused a lot of illness, a lot, the number of deaths that we were experiencing per day was less than what we were seeing with the previous versions of the virus. And you can see that comparing the peak in the middle bottom panel to the right side of the panel. So I can go to the next slide, please. I just want to show this picture showing the pandemic trajectory. As you can see, we were in really bad shape in November of 2020, which until recently was really our most challenging period of time. Most of the counties in Wisconsin had critically high levels of COVID-19 diagnosis every day. When we started vaccinating people, we really had a significant downturn in the case burden of COVID-19, and you can see that second from the left. Right before the 4th of July, we reached really our best situation since early 2020, with low to medium case burdens in most of our counties. As Delta and then Omicron challenged us, we actually had our highest case burdens ever in January of 2021. And you can see that every single county in Wisconsin had critically high levels of transmission. We're in a favorable trend on the downswing in terms of case burdens. And this is as of last Wednesday, and I expect that the situation will be even better tomorrow. But as you can see on the far right, we had 6 counties that were critically high. My legend is wrong there, and 66 that were very high. So a couple of points here. On the favorable side, we're clearly improving from where we were in January, and the decline in cases is very steep. So again, I expect that the county level data will be much better tomorrow than they were even last week. But the case burden is still high, and was in all of our counties as of last Wednesday. So it's just something to think about. When we think about our personal risk tolerance, one factor that isn't discussed enough is the community transmission rate in your locality. And it's still high. So that's something that you need to think about when you make personal choices about what mitigation measures you might want to implement. And that would include some back to work strategies for employers. So next slide, please. I just want to pivot to 2 final questions. One is, what is the Test to Treat initiative? I actually think this is remarkably positive and a smart thing to do. So this is part of President Biden's COVID-19 pandemic roadmap that was unveiled last week during the State of the Union address. And so what this really is a one-stop approach to testing and treating people that might have COVID-19. So the idea is that you can walk into a clinic at a CVS or Walgreens, get a rapid antigen test, and if it's positive, get a prescription for, and then leave the pharmacy with your prescription for oral COVID-19 medications, all in a very short period of time, say 30 minutes, from walking into the pharmacy to leaving. So this is important. There are at least 100 sites, CVS and Walgreens, that are ready to do this and have adequate stocks of either Paxlovid or Molnupiravir, which are the 2 oral pills that have emergency use authorization for mild to moderate COVID-19. There are some hurdles that need to be overcome before this becomes more widespread in the US. First of all, we need to make sure we have an adequate supply of reliable rapid tests. I think that we actually are in a pretty good situation there in terms of stocks of the tests. So that shouldn't be a burden that will be a problem for us. There does need to be a healthcare provider that can write the prescription to screen for each patient. Pharmacists in Wisconsin do not have that authority to prescribe. So this is a logistical issue, a challenge for us that needs to be overcome. And then having an adequate supply of antiviral medications. With the declining case burden of COVID-19 in the US, I believe that most pharmacies already have adequate supplies of these antiviral medications. So this shouldn't be a significant challenge for us. And then finding out a consistent way to report these positive tests, because this is breaking the current paradigm for which we only report positive PCR tests and not rapid antigen tests, and then following up with the person's primary care provider if they have one. So again, I think this is a very, very positive outcome and something that can help mitigate any potential future surges. Next slide, please. And then finally, I just want to talk about what is the difference between pandemic and endemic, and what does that mean for us in the coming months? So simple definition, a pandemic is the spread of a disease over a large region that often covers entire nations or continents that affects a substantial part of the population. So we already know we have that with COVID-19, and we've been suffering from that for the better part of 2 years. And another variable that people need to consider is that pandemics are unpredictable, and they have large swings with high peaks of surges and then low valleys when the surges dwindle. Pandemics end either when an infection dies out or reaches a relatively steady state. And we don't believe that COVID-19 is going to completely die out. So what we're really talking about is reaching a relatively steady state, which would be an endemic state. So an endemic is a state in which a contagious disease is present permanently in a specific region or group of people. In this case, it really would be the entire world. And the spread becomes more predictable and less variable, with perhaps some seasonal peaks and valleys. An example of this would be malaria. And it's important to cite this example of malaria because I want to make sure everyone knows endemic does not necessarily mean that we're going to settle in at a low level of community transmission. And we do not have a low level of community transmission of malaria, but it is a manageable and predictable level. So we still have the possibility that COVID-19 could settle in an endemic state at a level that's higher than low. And the CDC and the DHS definition of low transmission is pretty stringent. You're really talking about 10 new cases per 100,000 individuals in the previous 2 weeks. So that's a very, very low level. And we are not at that level right now. So thinking about what it's going to look like in the coming months, maybe years, some variables that we really don't have control of, but we need to follow. And there are 5 of them that could influence the progression of the pandemic going forward. First, will new variants of COVID-19 emerge that could challenge us, like Delta and Omicron did last year and early this year after we had a very significant lull in COVID-19 in the middle of 2021. Second, going forward, how durable will the immunity be that we achieve from vaccinations, boosters, and previous infection with COVID-19, especially with Omicron? Third, how favorable would the impact of COVID-19 oral therapeutics, these pills and capsules that I talked about in the Test to Treat initiative, be going forward? Fourth, in the US, will people continue to decide to begin their vaccination series or to be boosted, or have we sort of maxed out and we can expect waning immunity from the people that have already completed their course or been boosted? And then finally, worldwide, how quickly can the 1.5 to 2 billion people, predominantly in the Southern Hemisphere, who've not been vaccinated yet, gain access to effective COVID-19 vaccines? Because remember, a new variant that could emerge in another country in a largely unvaccinated population could boomerang back here and challenge us yet again. And with that, I'll turn this back over to Tim.
Yeah, thank you, Dr. Raymond. A couple questions. First one on the test to treat. Will other pharmacies beyond CVS and Walgreens participate in that?
I hope so. I think right now we're in the proof of principle stage. And if that works, I would hope that it could be available at local pharmacies that are not part of national chains. Again, the real barrier here is the differences in state licensures that would allow a pharmacist either to prescribe or not. And in Wisconsin, even though pharmacists have expanding scope of practice, they don't have that opportunity to be the prescriber. And so you've got to get somebody else involved.
Yeah, and then looking at your DHS data that you shared, it shows the state's only at 60%, I think, of full vaccination. Is that something that could start another surge?
Well, as we know, Omicron disproportionately affected people that were unvaccinated. And we would expect that new strains, if they do emerge, would have that same profile. Delta was the same way, that people that were unvaccinated, whether they had a previous infection or not, were up to 20 times more likely to have a serious illness or to die from COVID-19. So yeah, the more people we have that are vaccinated, the better off we're going to be, irrespective of their previous infectious status.
Yeah, Dr. Raymond, you and I have had a kind of a running discussion on the question for employers as we start to hear more and more employers having their employees return to work, you know, starting as soon as the end of April. how would you advise employers now in terms of, do you mask? What about the requirements of people coming back to the office to be vaccinated? It seems we came in with a lot of confusion, and now we're coming out, and there's an awful lot of questions about what plans do I continue to keep in place as employees return to office, and which ones can I shed?
Yeah, Tim, it's such an important question, and it's a very difficult one.
Yeah.
We're going through that conversation here at MCW. We have 6,000 employees, and many people think of us as an educational institution. And I've had some people say, Marquette, drop their mask requirements. Why can't we do that? Well, we are physically connected to healthcare facilities, Frederick and Children's, and literally thousands of our people move back and forth every day. So we're applying a healthcare standard to how we think about our mitigation measures. And so the point I'm trying to make here is it's going to depend on the employer and your circumstances, the comfort level of your employees with returning to work, or at least on-site work, whether you have an at-risk population of employees, maybe you have an older population of employees that you have to consider, whether people are spending lots and lots of time in close proximity with each other. You're going to have to think about your HVAC and whether you're getting those 8 to 10 air exchanges per hour. So those are all significant variables. I think the best advice I could give is, and this is just my advice, is not to rip the Band-Aid off. There may be some people that want that to happen, but to take graded measures where you reduce your mitigation interventions serially over time. We're actually doing that here at MCW. We're loosening up our density restrictions for people congregating in meetings and in the classroom. We went from 33% to 50% of posted occupancy on March 1. We're going to go to 100% of posted occupancy on May 1. We're loosening up food restrictions just in terms of whether people have to have prepackaged food, plated food, or can use buffets, and we're doing that over a period of time. And we're slowly bringing people back to work. We're having an ongoing, very lively discussion about when and if we'll make masks be voluntary rather than mandated on our campus. So, it's really a tough call, but I would just say one step at a time over the next few months is probably the right way to go.
Another difficult question. You always get the difficult ones, Dr. Raymond. What about business travel? Is it reasonable for employees to refuse to engage in required business travel?
Again, that depends on an individual's personal circumstances and their risk tolerance. So a cancer patient undergoing chemotherapy or somebody with a transplantation on immunosuppression, they could have legitimate concerns about business travel. But as the case burden in communities decreases, those concerns also should decrease. And they would have the option, even if masks aren't mandatory on airplanes anymore, to wear a high quality surgical mask or an N94 or N95 or KN94 to protect themselves. And I think business travel right now is probably relatively safe for most people.
Yeah, and the other thing we've talked about is companies that required employees to be vaccinated to come back to the office. Some now are saying at some point, as they phase in people coming back to the office, that those employees who weren't vaccinated can now come back to the workplace. And of course, the longer we go with the existing vaccinations, the less effective they are. And so as you think about this going forward, are we cycling back into a time frame now where it will be like a flu vaccination?
I sure hope so. Again, I gave you the 5 variables that we don't have a lot of control over that could influence in the coming months. But I think we'll get into a cadence where we probably have annual boosters for COVID-19, which is likely to turn into a seasonal endemic virus like the flu virus. And it's something that we should think about, but there's been no formal decision made. MCW, unlike UW Health, has not mandated boosters for people that have completed their series. UW did. We're hoping that we can incorporate that into the cadence of our influenza vaccination. If in fact we recommend that going forward, that would be a few months down the road. Great.
I cycling through, I don't see any new questions here. And unless you have some final thoughts, Dr. Raymond, again, I'm very appreciative of your joining us and keeping the facts in front of us as we begin to return to the office and think about this in a different way than a pandemic.
Well, Tim, what I would say is I'm looking forward to, and I'm sure everybody else is, not having to give updates about COVID-19 at some point in the future.
Yes, we're all looking forward to that. Not that, but we'll miss you.
Thanks, Tim.
All right. Well, thank you very much for joining us, and have a good rest of your day.